I am very honored and pleased to introduce our speaker tonight, Brent Forrester, who is Dr. Brent Forrester, who is the Dr. Francis Arkin Professor and Chair of Psychiatry at Tufts University School of Medicine, Psychiatrist in Chief and Chairman for the Department of Psychiatry at Tufts Medical Center, and Director of Behavioral Health also for Tufts. Dr. Forrester spent a quarter of a century of his professional career at McLean Hospital and Mass General Brigham, where he served as the chief of the Division of Geriatric Psychiatry at McLean and senior medical director for value-based care solutions in population health management at Mass General Brigham. Dr. Forrester is an expert in geriatric psychiatry, specializing in the treatment of older adults with depression, bipolar disorder, and behavioral complications of Alzheimer's disease and related dementias. He is a past president of the American Association for Geriatric Psychiatry, a distinguished fellow of the American Psychiatric Association, and has previously served on the board of directors of the Alzheimer's Association, Massachusetts, New Hampshire chapter, and chair of their Medical Scientific Committee. His research focuses on novel treatment approaches to manage the disabling behavioral complications of dementia, such as agitation and aggression. Dr. Forrester's work also includes the implementation and evaluation of collaborative care models for comprehensive dementia care within primary care medical settings. And with all of that being said, I am very pleased and honored to welcome you, Dr. Forrester. Thank you so much for joining us tonight.
Thank you, Chris, for your kind invitation, and to you, Kyle. And it's such a pleasure to see all of you today. I think Chris is going to share the slides, and we'll get started. So what I'd like to do over the next hour is to talk with you about the current state of Alzheimer's disease and related dementias from the standpoint of diagnosis, treatment, novel research approaches, and also really focus on what we can do as we age to keep our brains healthy. I like to keep this interactive, so I'll try to get through the slides. And while I go through this, if you have thoughts or questions or comments you want to put in the chat, we'll get to it at the end of the talk. But if you put it in real time, that's fine as well. So next slide. So as I just mentioned, we're going to go through the prevalence of Alzheimer's disease and related dementias in the United States, its impact, how we think about diagnosis today in 2024, and our current treatment strategies. I'd also like, as part of that, to really focus on some of the challenging psychiatric or behavioral complications of dementia, which often drives stress and burnout, often in family caregivers, and is often why people with dementia wind up in hospitals and long-term care facilities, possibly earlier than otherwise. Then I'd like to introduce some of the models of dementia care that have become increasingly studied and talk about some new innovation work from Medicare that's helping to support this. And then finally, discuss the healthy brain aging strategies. Next slide. So every March, I actually look forward to this every March because the Alzheimer's Association puts out their annual facts and figures report, which is usually a couple hundred pages long. And in it, they have a number of key slides or figures as part of their facts and figures. And this is from this year's report a few months ago. And I always find the data on dementia to be somewhat overwhelming. And so I want to highlight a few things on this slide. First of all, in the United States today, there's an estimated 7 million Americans who are living with Alzheimer's disease or other types of dementias. Now, what's not on this slide is that only half of those people are actually diagnosed. And of the half that are diagnosed, they're not coming to the attention of medical clinicians or making the diagnosis until they're already at the stage of illness where they're no longer able to drive or pay their bills. So there's a massive delay in recognition and in diagnosis for a whole variety of reasons we can talk about. Many of you already know this. But in order for us to take advantage of these new therapeutics that are coming down the pike and that some are on the market now, we need to diagnose people earlier. And to get the full benefit of improving the quality of care and the quality of life for people with dementia and their families, early recognition and intervention is critical. So that's prevalence and delay in diagnosis. But to just show one other aspect of this illness that's just staggering is the cost. Today in the United States, we're spending about $360 billion a year in healthcare dollars on caring for people with dementia. And nearly the same amount, $347 billion, in caregiving that is valued at that amount because of 18 billion hours of caregiving that family members and other unpaid caregivers provide. There are 11 million Americans providing this unpaid care. And there's a true, in some ways, epidemic buried within this epidemic of caregiver distress, increased risk for medical problems and psychiatric issues, and even the risk for premature mortality. 70% of dementia caregivers feel stress when coordinating care, and most, more than half, say navigating care for dementia is very difficult. And what's not on the slide, but has been a real focus of the Alzheimer's Association over the past number of years, has been the disproportionate impact of dementia on underserved populations based on race and ethnicity. These populations often are less likely to be diagnosed, but more likely to have the illness. And so efforts at recognizing dementia across different populations based on race, ethnicity, et cetera, is really critical. Next slide. So as a specialist in this area, and I didn't go into the details other than what Chris said in terms of me, but I've been a geriatric psychiatrist now for almost 30 years. I chose this field in part because it brought together psychiatry, neurology, and medicine in the care of older adults. And as I started to work with individuals with dementia and realized this is a family disease, I really became quite appreciative of the challenges that caregivers face. And one of the challenges is how to kind of make the diagnosis. And I've spent a lot of my career educating primary care clinicians on how best to make the diagnosis in a primary care setting where there just aren't enough of us around. I mean, in my field of geriatric psychiatry, we're one of the 3 specialties that really are expert in dementia care, in addition to neurology and geriatric medicine. But in my specialty of geriatric psychiatry, we're training a mere 50 new people a year, 50 in the entire United States in the field of geriatric psychiatry. We'll never have enough of us to go around to treat all the mental health issues. So that's where the models of care come in, which we'll talk more about. Like, how do you scale the expertise of someone who really understands this illness, how to manage it, how to help families? And it's really by a team-based approach, which we'll talk about. But the first thing is making the diagnosis. And despite all the fancy tests that we have today in 2024 with imaging and lumbar punctures and now increasingly blood-based biomarkers and genetics, at the end of the day, the most important thing that any primary care clinician can do, or any clinician can do to make the diagnosis, is to get a good history. Get the story from the patient, from their family members in particular, from others who are close to them. When did this start? What's been the progression? What symptoms have been the worst? How fast has it been? What are some other factors that might be contributing to this in someone's environment? What about medical problems? What about medication side effects? What about blood work, like thyroid dysfunction or vitamin insufficiencies? Any medical problem that could be causing the memory issue. And what's not listed on here, but also needs to be looked at, are psychiatric issues, which is in the middle there, as well as substances of abuse like alcohol or other drugs. Screening is really important, and we don't have a gold standard one test, right? If we had a simple blood test or a simple test, everybody would get it. We have a number of different screening tests that can be used. The Montreal Cognitive Assessment, I'll show you in a minute, is one that's widely used, but it takes time. It takes like good 10, 15 minutes. So there are tools that are available that are much quicker, like the mini-cog, and we'll talk more about that. And then one of the questions that comes up in primary care is, well, when would the primary care clinician need to refer the patient to a specialist like me or a neurologist or a geriatrician? And one of the reasons why is if there's a finding on the examination that indicates there may be some primary neurological problem, like a stroke or a tumor, like there's weakness on one side or a tremor, or a problem with gait instability, et cetera. And that's where you might want to do brain imaging, like with a structural brain scan, like an MRI or a CAT scan, to look for these types of problems. Or if there's somebody who's really early onset and they're young, or somebody who may have substantial psychiatric complications where they may want to see a psychiatrist. We'll talk more about the different biomarkers, but especially I wanted to mention that the PET scans. So there are 2 kinds of PET scans. There's the amyloid PET scan that can look for the brain, the abnormal protein in the brain that we think is associated with Alzheimer's disease, amyloid, beta amyloid. But there's also a metabolic PET scan that can look for a change in metabolism in the brain, which is often associated with the illness before the symptoms even become prominent. Next slide. So there are many kinds of dementias, and I always get this question, so I'll just say it right up front. Alzheimer's disease is one cause of dementia. And on the left are many other causes of dementia. And it's not an exhaustive list. There are probably about 60 odd causes of dementia. But we'll define dementia in a minute. But dementia essentially is a clinical syndrome. It's a series of symptoms. It'd be like saying, a cough equals cancer. Well, a cough is a symptom of many underlying biological problems, including you got something stuck in your throat, have allergies, or have cancer, or COVID, or an upper respiratory infection. But you can't treat a cough unless you figure out the cause. Same thing with dementia. Can't treat dementia unless you understand the cause. Can't treat cognitive problems unless you know what's causing the cognitive problems. It sounds kind of basic, but oftentimes we forget that. And we now know that there are many biological causes of dementia. It just so happens the Alzheimer's type is the most common, probably accounting for about 2/3 of all dementias. The Lewy body type, which often looks like Parkinson's disease with tremor and gait disturbance and visual hallucinations like seeing animals or people that aren't there. And a fluctuating level of cognition where people can look really clear and lucid at one moment and very confused at another. Another type is the frontotemporal type of dementia, which is 5 to 10-ish% of all dementias. It often presents earlier. There are many different forms of frontotemporal dementia. You have an absolute expert at MGH, a world expert, Dr. Brad Dickerson in this area of frontotemporal dementia, but it's one form of dementia, and it's often associated, but not always, with behavioral issues, depending on where in the frontal lobe the illness strikes. Anyway, here are some other causes as well. Next slide. So I mentioned the MoCA. This is one of many tests, but we've been increasingly utilizing it because it assesses 8 domains of thinking and memory. And you can see in the top 3 questions, this tests what we call visuospatial functioning and executive functioning. These are not easy questions. The first one on the left, you have to connect a number to a letter in alternating sequence. So you go from low to high, 1 to A to 2, and then where do you go from there? So the person has to recognize that you're alternating between numbers and letters, because that's the pattern, and that you're going from low, 1, to A, and then higher, 2, and then B, and then 3, and then C, etc. That's called a Trails test, and it really tests someone's ability to it's organization planning and decision making. It reflects that. The cube is, again, a 3-dimensional object, again, tests visuospatial skills. And then a clock jaw on the right, which may become increasingly challenging as the younger generation has never seen a clock. They only see a digital clock. This is an actual clock that we all grew up with. We have to draw the face of the clock and the numbers in the clock and put the hands at 10 minutes past 11. So there are ways to get points for those different aspects of the cognitive assessment. Then there's naming those 3 animals. People always get the one in the middle wrong. I won't ask people what they think it is, but if you want to put it in the chat, you can. And then memory. So this is a tricky memory test. So you don't get any points for the practice part, where you have to remember these 5 words: face, velvet, church, daisy, and red. You get a couple trials to remember them. And then later on in the test, the person who's asking the questions will then ask those 5 words. And if the person gets none of them, they'll start giving them cues. Either category, like for the color red, for example, you might say it's a color. Or a multiple choice cue. If the person doesn't get the category, you would say, is it purple, is it green, or is it red? So the different kind of memory problem you can actually pick up in this way is whether the person has a hard time storing the information in the first place, or whether they stored it there, but they're just having a hard time retrieving it, and they need prompts. So for example, if the person can't remember these words at all, but by giving category or multiple choice cues, they get them all, well, that means the storage is fine. It's just the retrieval that's hard. Like it gets into the file cabinet, you just have a hard time finding where in the file cabinet it is without the prompt. And this can give us a clue as to the type of memory problem it is. So somebody with Alzheimer's disease, the classic form of memory loss in Alzheimer's disease is rapid forgetting of new information. And the reason why people repeat their questions over and over again is that the part of the brain that stores new memories, the hippocampus, is not working right. And they can't store that new information. You can give them all the cues, and they won't get that information. That's a storage memory problem. It's classic for Alzheimer's disease. Somebody with a vascular type dementia or even cognitive issues and depression will have what we call a subcortical dementia or subcortical process, where they have retrieval problems, where you give them the words and they don't know them, but the cues allow them to remember. And then there's tests of attention with that digit span of 5 forwards and 3 backwards. Reading a list, when I say these letters, please tap your knee when you hear the letter A. That's another attentional task. And then subtracting from 100 by sevens down to 65. And then there's a language cue where you have to repeat sentences, and abstraction where you have to see how two things are alike, and then finally orientation. Now, someone whose language skills are intact and their memory is great, and they've got good social skills, but they can't do the trails on the top or the clock. You may miss this in a casual conversation, and a primary care doctor would definitely miss this if all they asked about was the the day and the week and the month and the year. So anyway, that is one test of all these domains, 8 domains of cognition. And the most important thing to know about this test is it's a screening tool. It doesn't make a diagnosis, but it allows someone to see the relative strengths and the relative weaknesses of these various aspects of cognition that one can then track over time. And if this is abnormal in terms of the score, and again, the score is relative based on education, age, et cetera, but generally a score of 26 or higher is normal. But if you've got a PhD from MIT or Harvard, and you worked as an aerospace engineer, and you had great language skills, and then you get a 28, that might not be normal. That might be a decline from a previous baseline. Somebody with an 8th grade education where English was a second language, and although this is translated in other languages, that may still be normal. All right, next slide. So I mentioned the imaging. So I just want to give you a picture because it's worth 1,000 words. The MR stands for MRI, or magnetic resonance imaging. That's a structural picture of the brain. That's the gray, okay? And the group of 2 columns on the left are the Alzheimer's brains, and the controls are on the right. And if you just look at the gray on the right, you see that brain there. Now look at that image and compare that control image to the gray on the left. And what you can see is, if you look closely, you can see that there's less of the gray matter in the brain. There's more black than gray, and that just refers to the development of what we call atrophy, or shrinking of the brain. A PIB is a Pittsburgh compound B scan looking for brain amyloid, which is the sticky amyloid plaque substance in the brain that is the hallmark, along with tau protein, of Alzheimer's disease. In the control side, it's all blue and purple. That means there's been no uptake of this radio tracer in the brain, and that's the normal brain. There's no amyloid. But on the Alzheimer's brain, the red in particular, that's amyloid. And that's the amyloid that shows up in the brain often, as we'll see in a minute, maybe a couple decades before there are even symptoms. So it's an early sign of the illness biologically, and it's the hallmark of the illness. And as we have developed new therapies to remove this from the brain, we'll talk more about how effective those are. But that's what we mean by targeted therapies that are modifying disease, or when you target that red stuff in the brain, the amyloid, and try to remove it, make it more look like the brain on the right, which is the purple and the blue control brain. Next slide. So this is getting to what I just talked about. If you think about the cognitive function on the x-axis, so the higher up, the better, and down is worse, and then years from left to right. So the 3 stages that I want you to think about are preclinical, MCI, and dementia. Dementia refers to the syndrome of cognitive and functional decline. It doesn't say what's causing it. It's just cognitive decline in one of those 8 domains I just showed you, or difficulty with some daily activity. It could be driving, paying the bills, working, relationships, or basic activities like dressing, bathing, grooming, etc. When you combine a functional deficit with a cognitive problem, that by definition equals dementia, assuming you exclude other medical issues, etc. If you move backwards in time, the precursor to dementia is what we call MCI, or mild cognitive impairment. This is a syndrome of memory loss, some cognitive decline, but normal functioning. People with MCI are functioning normally, generally speaking, in their daily life. Then there's the preclinical stage. And the preclinical stage means that somebody is normal, no cognitive deficit, no memory loss, and no functional decline. But they've got the disease of dementia in their brain. And if it's the Alzheimer's type, it's amyloid plaques and neurofibrillary tau tangles, which means that people with preclinical disease have a disease with no symptoms. So if you go click one more time, Chris. And one more time. If you look at somebody who's got dementia today at the age of 75 with cognitive and functional decline, and they've got disease in their brain, if you go back in time by 20 years, That's the beginning of the deposition of the amyloid in the brain. Amyloid comes down first, then the tau, then there's degeneration of brain cells, and then there is the symptoms of MCI and dementia. But someone diagnosed today likely had the gradual buildup of this disease of amyloid and tau over 20 years. So the opportunity here is the preclinical stage and the MCI stage. The earlier we get people and try to remove the plaques and tangles eventually from the brain and try to actually impact some of the other biological processes we can talk about, the more likely it is that we'll be able to prevent things. And one of the really exciting areas of research is that some of the non-pharmacological approaches, like through diet and exercise, may be quite impactful in slowing this progressive downhill slope, which is represented by the dotted line. Last thing I'll just say about this slide is, if you see the aging on the right side of that graph, which is the dark line, the solid line, even with normal aging, there's some decline, right? So there's some decline in cognition with normal aging, but the slope of the decline is nothing like the slope in dementia, and there is no functional consequence to that. Next slide. So why do people get Alzheimer's disease in the first place? The top 4 reasons are things we have no control over, and the bottom 5 reasons are things that are modifiable. So let me break those down a little bit for you. So the number 1 risk factor for developing dementia beyond anything else is how long we live. And that is why we are seeing such a rise in the prevalence of dementia in this country and around the world. It's because we're living longer. And if you look at everyone in the United States over the age of 65, about 5% of those people will have some form of dementia. 5% over the age of 65. But as you go up by every 5 years, that number nearly doubles. So by the time you hit 85, depending on the studies you look at, you've got 30 to 50% of the people, 85 and above, in that population who have dementia. Now, that means that 50% or more of the people at the age of 85 don't have dementia. But the longer we live, the more likely we are to get it. So there's the age factor that unfortunately is sort of, we can't stop that. Can't stop time. Genetics we can't change either, at least not now. Let me briefly break down the genetics because it's complicated, but there are 2 different things I want you to remember. One is, in rare families around the world, there are these autosomal dominant genes, which you inherit from a parent. And if you get one of these genes, presenilin 1, 2, or the APP gene, those 3 genes, if you get one of those genes from one parent, you will get the syndrome of dementia, and you will likely get that syndrome young. And by young, I mean as early as in your 20s and 30s and 40s. That's highly, highly unusual. That is not even the typical early onset dementia. That is the unusual autosomal dominant early onset dementia. But they do exist in cohorts, in families, the most famous of which is in Colombia, South America. That's the Colombian cohort of about 5,000 family members who are being tracked and treated and followed, and they often will have onset of illness very young. Now, then there's the risk factor gene. This is not a determinant gene like the one on the other 3. The ApoE4 allele is a risk factor gene. You get 1 copy of the ApoE gene from each parent. You can get a 2, a 3, or a 4. If you get 1 or more copies of the 4, you have a higher risk of getting Alzheimer's type dementia later in life, but it's not determinant. It's a higher risk. It may be 2-fold the risk, maybe 3-fold the risk, but it's not 100% by any stretch. And as I'm doing a number of studies with my colleagues over the years and we getting genetic testing, I'm realizing we're seeing a lot of people who meet all the criteria clinically for Alzheimer's type dementia, and we get their ApoE4 status and they're negative. And so there are plenty of people who have ApoE4 who don't have dementia, and there are people without ApoE4 who do have dementia of the Alzheimer's type. And so we just need to remember what it can be useful for. And as we talk in a few minutes about the new therapeutics for Alzheimer's disease, I will highlight for you why getting ApoE4 testing is now clinically relevant. Because if you're a candidate for those treatments, having 1 or more of these copies puts you at high risk, not of response or lack of response, but it puts you at high risk of having side effects from the medication, which we'll talk about. People with Down syndrome, trisomy 21, they're more likely to develop and almost universally will develop dementia at a relatively young age. And then a family history. And again, the family history, what's important to remember as a family history is if you got a mom or a dad who had dementia and they got it young, like less than 65, way more likely for there to be a genetic risk to you than if they didn't get it until they were 85. The older someone is with dementia at onset, the more likely it is that there are multiple dementia pathologies involved, like stroke plus amyloid, and the less likely there's a family genetic component. Now, the good news on this slide is there's a whole bunch of factors that are modifiable. And as we talk at the last part of this discussion on modifiable risk factors for the development of dementia, the reason why healthy brain aging interventions like exercise and nutrition are so effective is because they address a lot of what's here and modifiable. High blood pressure, diabetes, and hyperlipidemia are all risk factors for cardiovascular disease, heart attack, and stroke. And so if you can modify risk and treat diabetes, hypertension, hyperlipidemia, reduce depression, and keep people away from drugs of abuse and alcohol, you're actually proactively able to preserve brain function with advancing age. So there are modifiable risk factors we need to remember. Next slide. So I want to talk for a few minutes about the most common complication of dementia that is often ignored by a segment of the clinical providers who are treating these patients, because these behavioral and psychological symptoms are not the target of new disease-modifying treatments, but they are indeed the most disabling aspect of dementia. They're nearly universal. They're associated with caregiver burnout, long-term care placement, and a higher risk of morbidity and mortality even. They include a whole range of symptoms like apathy, which is lack of motivation, depression, agitation, sleep disturbance, irritability, etc., and hallucinations and paranoia. These symptoms may be due to one of three big types of causes. It could be the disease itself, changes in the brain, neurotransmitters, atrophy, connections between brain regions. Those may actually contribute to the manifestation of these psychological symptoms. Or it could be due to medical problems like pain or constipation or infection, and very important, or medication side effects for that matter. Or they may be responses to changes in the environment, like the time of day, sundowning, for example. It's associated with agitation. As the sun goes down, the agitation goes up, changes to the sleep-wake cycle. The way in which a caregiver is interacting with their loved one with dementia, the tone of voice, the nonverbal stuff really matters. Now, despite the prevalence, over 90%, the impact on symptoms for patients and quality of life for patients and their caregivers. Up until this slide needs to be adapted, up until last summer, there were no FDA-approved medications for the management of any of these behavioral and psychological symptoms of dementia. There's now one. It's an antipsychotic medication called brexpiprazole or Rexulti. There's nothing magical about why that versus the other antipsychotics are not approved, other than they did the studies more recently and the FDA gave it its indication. We could talk more about that in the Q&A. Next slide. So I already talked about the three buckets of causes of behavioral and psychological symptoms. If I get a call in the middle of the night from a family member saying Mrs. Jones is agitated, I need to understand a lot more than just that. I need to understand what are the symptoms really, and how severe are they, and what prompted them in the environment, and was there a change in routine, or is there something else going on from a cultural standpoint, or the way in which caregivers are interacting with them. So I look at environmental causes, medical causes we talked about, you can see on the slide here, and then psychiatric causes as well. And it's not just the degeneration of the brain we talked about, but if someone has a pre-existing history of a psychiatric illness like depression or bipolar disorder, it actually increases their risk of developing dementia. And it doesn't prevent them from developing a recurrent episode of depression or mania in the setting of dementia. And the treatment approach, in terms of duration and medicine use, will vary depending on whether the depression occurred earlier in life, now they're older with dementia and depression, or if the depression only occurred later in life after the onset of the dementia. The approach to treatment varies and the response to treatment varies. Next slide. Now, I'm not going to go through the medicines that are approved by the FDA. Brexpiprazole is the only one, but the other medicines we use for these behavioral symptoms of dementia, I'm happy to answer in the Q&A, but we use a lot of medicines like antipsychotics and antidepressant medications and mood stabilizers. We could talk more about that. But a lot of the focus of treatment in the neurological setting is often on the cognitive symptoms and the functional symptoms. And there are two classes of medicines that have been approved as symptomatic therapies. The first were the cholinesterase inhibitors. These are medications that just increase acetylcholine levels in the brain, a neurotransmitter. And they do it by blocking an enzyme that breaks them down, essentially, in the synapse. Donepezil is also known as Aricept. Rivastigmine is Exelon, and galantamine is Razidine. Some of these may be familiar to you. All these medications are relatively well tolerated, and we'll get to that in a minute. But what's important to know is that they don't alter the course of the illness. They slow the decline, and they do it for a period of time. Now, the other class of medication is a glutamatergic drug that blocks the chemical, like cytotoxic effects of glutamate, and that's called memantine. Nowadays, and again, standard of care in 2024 for people with the Alzheimer's or the vascular or the Lewy body type of dementia is a cholinesterase inhibitor at a therapeutic dose plus memantine. Now, if we knew who would respond and who wouldn't respond, we probably could reduce the numbers of people we treat until we find one responder. Be that as it may, they have some symptomatic benefit for a period of time. And if you stop the drugs too quickly, there can often be a more rapid decline over a short period of time. Next slide. So one other thing I'll just say about those drugs. Side effects from the cholinesterase inhibitors include stomach, like nausea, vomiting, loose stools. And it can also reduce the heart rate and make people dizzy. So we have to be very careful about that and make sure families are aware of those side effects. Now, I want to move for a few minutes into the new therapeutics. And what we've been doing to date from that first drug, Tacrin, approved in 1993, so for the next 33 years, for the next 30 years, essentially, no new drugs on the market, either cholinesterase inhibitors or memantine. Just like I said before, symptomatic therapies. You remove them, the benefit's gone. These drugs are very different drugs. First of all, they target amyloid plaque in the brain, or tau, but the ones that I'm going to focus on are amyloid. And they reduce either the buildup or enhance the breakdown of this amyloid, beta amyloid plaque in the brain. These are often immunotherapies delivered via an intravenous infusion over the course of a fairly, about an hour, but like the one that's on the market we'll talk about, lecanemab, is infused every other week for a period of 18 months. Now, both of these proteins can be seen with amyloid or tau PET scanning, which means we can visualize the proteins before treatment and see that they're essentially removed after treatment. Next slide. So the first drug that got studied, and frankly, the first drug that got approved with a lot of fanfare and controversy, was aducanumab. This is the Biogen drug that got a lot of press and bad press, frankly, a number of years ago. It's approved 3 years ago this month. The initial phase 2b trial, this was the primary outcome you can see here. What they did was they looked at relatively small numbers of patients in the 100-ish category. And on the left-hand side of the slide are baseline amyloid PET scans. So in the 4 different conditions, a placebo in the top row, 3, 6, and 10 milligrams a day. People at baseline looked as they did on the left in red, and the red is amyloid. And the placebo patients, the top right, are red, no difference. You give them placebo, amyloid's still there. But if you give them 3 or 6, or especially 10 milligrams per kilo of aducanumab, you definitively remove that amyloid plaque from the brain. And this is after 54 weeks, so essentially a year. Now, what this does not tell us is whether or not people's symptoms improve, or more likely, their decline slows down. So the slope, instead of being like this, goes more slow. So this study was wildly positive. So Biogen, the manufacturer, went to the FDA and got approval to move from a phase 1b study to 2 very large phase 3 studies. Now, those studies were controversial. One was positive and one was negative in terms of its clinical outcome. And the FDA approved it not based on its clinical effect. They approved it based on its ability to do what you're seeing on the slide, which is remove amyloid. And Medicare wouldn't pay for it, and it's essentially now been withdrawn from further drug development by Biogen. It doesn't mean the drug doesn't work. It just hasn't been approved and it's not being developed further. It could potentially still be used, but there won't be any insurance coverage for it. Now, next slide. The second of these antibodies is called lecanemab or Leqembi. This was the first publication of the findings of the phase 3 trial in January of 23, about a year and a half ago. This is an antibody, a monoclonal IgG1 antibody, again, intravenously infused every other week. It binds to the A beta protein, the protofibrils in the brain. And over the course of 18 months, people were given twice monthly infusions. And the drug placebo difference on a measure of cognition was 27%. What in the world does that mean? Does that mean someone's driving again if they couldn't drive? Does that mean they have more time before they lose quality of life? It really is just a change in cognition and function pre and post treatment, drug versus placebo. Now, the important thing to know about this drug and the same drugs is that there are two side effects we worry about. One is infusion-related reactions. These are generally mild and time-limited. It's like having an allergic immunologic response to any kind of foreign body. People can feel dizzy and nauseous. They can develop a rash. They can feel itchy. They can get a headache. They can be tired. 1 in 4 develop some of these symptoms, and they're very time-limited over the course of hours or days. Things like antihistamines may help, etc. But the concerning side effect is brain swelling and brain bleeding. We call microhemorrhages or cerebral edema. Now, the percent of people who develop this, 17% and 12.5%. A couple things to know about this. Number one, you're more likely to get these side effects if you have 1 or more copies of that ApoE4 allele. So some centers are not delivering this drug with people who have both copies of the Alzheimer's gene, which is frustrating. Now, some are doing it, but there's a higher risk. The other thing that's important to know is that the vast majority of the people, and I mean vast, who get these MRI findings of hemorrhage and swelling, the vast majority of these people don't have any symptoms. They have no dizziness or headache or anything. Now, full approval was granted for this drug exactly a year ago. It's being scaled, MGB and elsewhere, and auto-injectors are under development. What does that mean? Well, that means that later this year, there may be a drug on the market, this drug, but it's not delivered via an intravenous infusion in your vein every 2 weeks in an infusion center. You can inject it at home with a little tiny needle, almost like an insulin injection. And you can do that over the course of the period of intervention, which again, for this study will be 18 months. But we'll see what the results of safety and efficacy for the auto-injector look like. Next slide. So if you look at the drug placebo difference here, you'll see it's modest, but the baseline is 0 at time 0 on the left, and 18 months is on the right. You can see that. And the dark line is placebo. So the lower you go, the worse your cognition and functioning. The higher you are, the better. So you can see the lecanemab arm still declines over 18 months. There's definitely a decline. But there's a statistically significant difference between the 18-month effect and the on drug versus placebo. Next slide. So now I'm going to move away from drugs to try to think about a more holistic approach for people with dementia and their caregivers. And Chris has been involved in this team that we launched at MGB back in the great timing in the winter of 2020. This model is based on a series of studies conducted by my colleague, Dr. David Rubin at UCLA, where he created a model called the Alzheimer's Dementia Care Program, or ADC. This model pairs a social worker like Chris, dementia care manager, with a geriatric nurse practitioner and a supervising dementia care physician, could be a geriatrician or a geriatric psychiatrist, et cetera, with the patient and their caregiver in the middle of all of this. And the primary care provider can make the referral directly, or we have a registry of people who have been diagnosed and we can pull the names out of a registry, or they may be on an Alzheimer's medication, so we can find people that way. Or the person may have symptoms, or we may do screening, but any which way they get in, they get an assessment by this team. And there's a diagnostic disclosure and a conversation about serious illness, and there's a care plan that's developed. There's a lot of attempt to reduce unnecessary medications. We call that medication deprescribing. Sometimes in geriatric psychopharmacology, I call it, less is more. Moving away medicines often makes things better. There's a lot of caregiver support provided through this program, and there's a connection to various specialists. So some of these folks actually need to see a neurologist or a geriatric psychiatrist, but they can be connected to this navigation approach. Next slide. Now, as we rolled that out at Mass General, the Brigham, and Newton Wellesley in 5 practices, one of the things I realized was that this was an expensive model. I mean, we were paying people to do this work, and there wasn't a lot of reimbursement that was realizable at the time because a lot of the codes hadn't been built yet, but now there are more codes to do billable service with that model. But Kate Posey and their colleagues at UCSF developed this really interesting model called Care Ecosystem. And Care Ecosystem essentially has a non-clinician at the center, a CTN or a navigator, a non-clinician dementia care navigator, and the patient and the caregiver dyad. And they interact with the patient caregivers by doing a few things. They collect an assessment of both. They do a caregiver assessment and a patient assessment. And then they deliver 7 modules that really reflect sort of gold standard dementia care. And there's a team around them of clinicians from the healthcare community, nurses, social workers, and pharmacists. Next slide. I think I have a picture, yes, of the intake assessment in blue. And these are the 7 modules that we would train. We adapt this, by the way, for nurses. We're developing holistic care for people who had dementia in primary care settings. And they assess for immediate needs, make sure they appropriately prescribe medicines and get rid of medicines that aren't necessary. They screen for safety concerns and make sure that the house is situated so that there's a reduction in safety concerns like wandering, mismanagement of medications, driving, etc. Referral and intervention of caregiver support, caregiver well-being, behavioral symptom management of the patient, and advanced care planning. Does this person have the capacity to make decisions about their future? Oftentimes the answer is yes, early on in the illness. And people with dementia need to be actively involved in developing their own plan of care for when they get older. And not just older, but more impaired. Next slide. So a year ago, I got this idea that I would take a new job. I don't know why I did that, but I did that. I think I mainly did that because it was an opportunity to build better models of care for behavioral health like depression, anxiety, and substance use, as well as dementia care in a system that did not have the depth of expertise that I found at MGB. So I've had a lot of fun in the last year, meeting a lot of new colleagues and thinking about ways to have an impact. And one of what I wanted to do, one of the things that I wanted to work on was to build a memory care program at Tufts Medicine. And the 3 circles that are represented here exist in many healthcare systems, including at MGB, but they're not linked together closely. And I know that because I helped work on the systems at MGB. So on the bottom right is a standard, very typical specialty memory clinic that you'll find at an academic health system. It likely pairs neurology and psychiatry and medicine together, along with neuropsychology and social work. May have access to occupational therapists for home visits and safety evaluations. But that specialty memory clinic helps with evaluating complicated and confusing diagnoses. Is this depression or is this dementia? Is this frontotemporal dementia or is this Alzheimer's dementia? And staging it and so forth. And screening people to see if they would be eligible for the circle on the top, which is the Alzheimer's Therapeutic Program. This would be the ability to safely deliver drugs like lecanemab, which you just heard about, in an intravenous infusion. But the third most important or as important part of this model is the bottom left, which is the primary care-based holistic approach to dementia care. I just gave you 2 examples of dementia care models, ADC and Care Ecosystem. And there's a new program, and if you go to the next slide, Chris, I don't know if I put it in here. No, I didn't. You can go back a slide. Just, I didn't put this slide in, but let me just tell you, last fall, the Center for Medicare and Medicaid Innovation, this is a wing of Medicare, which was developed under Obama's Affordable Care Act that came out in 2010. But the CMMI, this innovation platform, is a really amazing new way to provide a payment structure for intervening with the care models that I just described. So it's called GUIDE, or Guiding an Improved Dementia Experience. And it involves care navigators, social workers, supervising physicians to deliver this holistic dementia care model. And there are about 8 or 9 or 10 different outcomes that have to be tracked. It also provides support for respite care for families who want to do that. It really emphasizes de-prescribing unnecessary medications, supporting families, and reducing behavioral symptoms. And so we're now all scrambling, those of us chosen to be an intervention site as we were at Tufts, and I know McLean Hospital and the MGB system is doing this as well. We can enroll upwards of 200 to 300 patients a year, provide them with this dementia care model, and actually generate revenue and at least break even off of the care that we're providing. Up until now, there's been very little way to develop or to implement a dementia care model like I just described through traditional Medicare. That's why this new model. Okay, next slide. So this is not meant to be a public relations piece, but Tom Harrison is a law journalist, amazing writer, came to me a few years ago and said, Brent, I have a book that I've been working on, and I have an idea for how best to manage people with dementia, support their families in particular. And we put this book together called The Complete Family Guide to Dementia. It's everything you need to know to help you parent yourself. It was designed for adult children, but really it's anyone in the family. And it provides a resource for family caregivers. I just want to highlight a few points of the book, and you can get this on Amazon. It's really inexpensive. And it's a really helpful guide. I've been amazed at the number of times I talk about this with Tom in public audiences. And I realized two things. I realized that there's a huge thirst for this information. Like people really want to know this stuff. And then the second thing is, oftentimes people just don't know this stuff because there really is no one roadmap when you have a loved one with a memory problem. It's confusing, but this book tries to provide that roadmap. Next slide. So a few of the principles we talk about is that, sometimes families, and I will count myself as one of those families with a mom who's got some early signs of cognitive decline and has not been appropriately worked up because of all the different issues that come up. But one of the problems that families make, and we all make it, is delaying diagnosis and treatment. It's not just because clinicians are not screening for it in primary care. It's because families often are not noticing a problem, or the patients don't notice it either because they're not aware of it or because it's so gradual. But it's gradual and its onset and progression. It looks a lot like normal aging. Like, how do you know if it's dementia or normal aging? And there are ways to assess it, like we talked about. But there's also psychological reasons. There's the minimization of, oh my God, this is so scary. And I don't want to have dementia, so I don't want to know about it. Or the families are like, in denial because they don't want to deal with the fear and the grief involved in knowing what's going on. And I would argue that knowing what's going on is critical to make an appropriate treatment plan and reduce bad outcomes. Unlike a heart attack or cancer where, you get the diagnosis and immediately everyone swarms in to help, there's no urgency in making the diagnosis in dementia. I think part of it is because of the top reasons, gradual onset, slowly progressive, et cetera. But part of it is because I think there's been a sense of what I would call therapeutic nihilism in the primary care community. Medical community is not often educated or supported in making the diagnosis and developing treatment plans, in part because this therapeutic nihilism that treatments actually matter. And I would argue they do matter. Not just the biological treatments that we talked about, but also the supportive care for families and engaging people in meaningful activities socially and also with their brain and with their physical exercise. And then there's another mistake, which is that, in terms of making the diagnosis, gets in the way is stigma and fear. And I'll just say that, in 2024, in some ways, we're in the stage of the field of dementia where it's highly stigmatized. Often people don't like to talk about it. Primary care doctors don't feel comfortable looking for it because they don't have a biomarker. They don't want to make the diagnosis. We don't really have many treatments that are that effective yet. It's not unlike where cancer was in the 1970s, 50 years ago. Same thing, stigmatized, lack of clear biological markers, medications that were more toxic than helpful. Everything has changed in the world of cancer in the last 50 years. And there's no reason why we can't see the same kind of change in terms of early diagnosis and the development of these care pathways that I was just talking about for dementia patients, whether they have the Alzheimer's type or other types. Next slide. The other thing we highlight in the book is the importance of being proactive and not reactive, and of caring smarter and not harder. And making a plan is what it's all about. So one thing that comes up is the nature of your relationship with your parent or your spouse changes because of dementia. Oftentimes there's the role reversal, et cetera. That's difficult, but you have to recognize it so you can deal with the consequences of that, the way you feel about that, and so forth. We talk about how to focus on loving and caring for your family member and how to get the support around you that you need so you can be that son or that daughter or that spouse or that sibling for your loved one. We have to understand that we're all going through grief when caring for somebody with dementia. Whether we know it or not, we're grieving the loss of the person we once knew, and depending on the nature of the relationship, Could be complicated grief because of the challenging nature of the relationship. But this period of grief and mourning is not over in a week or a month. It's long, it's extended, it can go on for years. It's exhausting. And oftentimes, like in grief, we may have the shock of it. We may get angry about the diagnosis. We may be sad about it for a while. Eventually, we need to learn how to accept it. And people who do well at home, because their caregivers are feeling supported and not depressed and very engaged and not anxious, they're dealing with these kinds of symptoms. Because if you don't deal with grief and mourning, the symptoms eventually erupt and cause problems. So it's really important to take care of yourself. Caregiving itself is a risk factor for premature death, and it's easier said than done by me, but I've seen countless family members of my patients die way too soon and abruptly because of the stress and the premature death involved with caregiving. Next slide. And then along the lines of caring smarter and not harder are a few other things. Common challenges, driving, psychological and behavioral symptoms of dementia we always talked about, and making sure that people are able to express their wishes for what they want the end of care to look like. Driving is a whole nother story, which we don't have to get into the details today, but I would argue that it's almost impossible, or maybe just really difficult, for a family member to be the bad guy. It's really uncomfortable for the family member to say, you can't drive anymore, Mom. You know, I actually went through this with my parents last year, and I actually had to say in the midst of a crisis, a medical and a psychological crisis with my dad, and I saw my mom's decline, and I said, you know what, for now, given all that's going on, and we brought this aid in to help you, let them drive, let them relieve the stress of it. And that was the beginning of the no longer drive. It actually went well, and I think, unfortunately, it took a crisis for it to happen. But more often than not, the successful way of doing this is engaging the doctor as a family member. Please, could you help me with this? And have the doctor talk about this. Now, as a clinician, somebody who's really early stage illness and they're still driving, how do I know if they can still drive safely? I can do some of the cognitive tests that I showed, but the best way to do this is to do a real test, a road test or a simulated test or both, and have the Registry of Motor Vehicles or a DriveWise program like they have in Boston at some of the hospitals like BIDMC get involved with a DriveWise program. And then finally, long-term care planning is critical. And, you know, how do you think about the future? When you can't do this on your own, what do you want home care to look like? What do you want long-term care to look like, et cetera? So again, caring smarter and not harder, and really thinking about being proactive and not reactive. Again, easier said than done, but this book has a lot of tips on how to manage this. Next slide. So finally, I want to talk about what can we all do to keep our brains healthy with aging. So 7 years ago now, the Lancet Commission came out with this amazing report. They looked at tons of studies, and they decided that based on those studies, you could prevent a third of all dementias if you address these risk factors at these various life stages. Early in life, we know that lower education increases the risk of dementia later in life. And in middle life, interestingly enough, hearing loss of all things, hypertension, obesity are risk factors for subsequent development of dementia, and reducing those risk factors will reduce the risk of dementia. And then late life, smoking, social isolation, physical inactivity, diabetes, and late life depression. All of these factors, these 5 + 3, 8 + 1, 9, are modifiable risk factors, but they don't come in a pill or in an infusion. They come with proactive behavior change. So it requires coaching and dedication and patience. And there are programs now that are set up through tech support to kind of deliver these types of interventions. Next slide. So one way to think about what you all can do is this acronym my colleague Jim Ellison came up with called DANCERS, which is disease management, activity, nutrition, cognitive stimulation, engagement with others, relaxation, and sleep. I'll go through this pretty quickly. Next slide. There is a book that the Harvard Medical School put out, which are 6 steps to optimizing brain function and improving brain health. And a lot of it has to do with how to build cognitive reserve and a multi-pronged approach to integrate interventions for better nutrition, for exercise, for reducing stress, for sleep, and for psychosocial stimulation. Next slide. All right. So I went through a lot in about an hour. We've got plenty of time for questions, but I just want you to remember the following: that dementia should be proactively diagnosed. The earlier we diagnose people, the more they and their families get involved in care planning and thinking about how the future should unfold. It's important to be proactive, not reactive. There's a lot we can do despite having a diagnosis of dementia, as opposed to what we can't do. So the focus of treatment really needs to be on improving not just cognition or slowing cognitive decline, but stabilizing functional loss and especially improving these behavioral and psychological symptoms. We want to improve quality of life and support caregivers throughout the caregiver journey of dementia care. And we need to think about modifiable risk factors to reduce the risk of dementia. And when possible, even with cognitive impairment, to intervene with nutritional and exercise interventions, as well as brain stimulation, social engagement, and all will help, even in the setting of dementia. And then finally, there's now a payment mechanism. So some demand has been created for these integrated dementia care models to help provide comprehensive assessment and value-based care within a primary care setting. Next slide. I think that may be it. Oh, one last thing. Next slide. I've been involved with a lot of research over the years in Alzheimer's disease, and I want to tell you about one study. Some people asked about getting care, et cetera. If you or a loved one may be in the early stages of dementia of the Alzheimer's type, MCI or mild Alzheimer's disease, we're involved in a 5-year federally funded study by the National Institute of Aging to look at the ability of a vitamin compound, vitamin B3, called nicotinamide riboside. You can buy that over the counter in high doses of 1,000 milligrams a day, a gram a day, whether this vitamin essentially may play a role in 2 brain functions that we think go awry in dementia. One is oxidative stress, and the other one is energy metabolism. So we're going to measure markers of oxidative stress called glutathione and energy metabolism in the brain using an MRI-based technique called MR spectroscopy. So it's essentially MRI scans. So people come in, they get evaluated, they get their genetic testing to make sure they got one copy of the allele, they get cognitive testing, they have either very mild cognitive impairment or mild Alzheimer's disease, they don't have any metal in their body, so they can undergo an MRI. And we're looking to see whether or not some of these biomarker changes are there at week 6 or week 12, and also how people do clinically. So again, if you have anyone of interest, I have contact information on the next slide. You can either email me or our research assistant or my executive assistant. I actually will, Chris and Kyle are going to pass these slides around. So anyone who was here and is given their email, you can get a copy of these slides. Next slide. I think we're over. So I just want to thank you so much. You can click out of this, Chris, for your attention. You guys, hopefully this was helpful. That was a ton of stuff. And I think maybe, Chris, do you want to go through the chat first, and then we'll go from there?
Yeah, so I just want to remind everybody that if you have any questions, and first of all, thank you, Brent, for the amazing presentation. I think there's a lot of information given, so would love to field some questions from everybody here. So please feel free to type it down in the chat box there. I'm going to go through them as best we can with the time that we have left. I'm just going to go from the top to the bottom. So again, please feel free to type it out, and I will, hopefully we can get to everybody before we end today's session. So, all right. So looking here through the comments. All right, so the first question comes from Marina, who asks, how do you treat people whose native language isn't English?
So Marina, thank you for that question. I think this is something we struggle with because as I mentioned, some of the cognitive tests are very language dependent. The good news is they've been translated into many languages. And in the Boston area, we have a lot of clinicians who speak numerous languages. And even short of that, we have language lines that we can tap into to basically be there in the room with the clinician and the patient and their family member to help with the language translation. But the best thing to do is to do the assessment in someone's native language. And there are a number of clinics and centers in Boston that cater to people who are speaking different languages. So for example, at MGH, I know there's a wonderful group that has Spanish-speaking neuropsychologists. But there is a lot of, I think there's a lot of complexity in doing the assessment. But the bottom line is, as long as you're aware that the language difference may impact performance, you can take that into account as well in your assessment. So there's that part of the language is the neuropsych. And then the other part is, of course, communicating with patients and their caregivers. So we have to make sure that we have those capacities either through translation services or through clinicians who can speak the language.
The next question comes from Paula, and Paula asks, is the memory care program accepting patients at Tufts Medicine?
So the program I described to you for Tufts Medicine is in evolution as we speak. We currently have numerous clinicians within the Tufts Medicine family, both at Tufts Medical Center in Boston, as well as in our community sites that extend all the way up to Lowell, who are doing dementia evaluations, neurologists, some geriatric psychiatrists, neuropsychologists, social workers, and we're now delivering the disease-modifying therapeutic lecanemab up in Lowell to start with. And we're accepted into the guide model. So we're building those dementia care models in primary care. So the answer is yes. If you had a family member who needed a dementia evaluation, you could get in touch with me. Again, the contact information on the folks in the slide deck that you'll get. And we can refer you to somebody within our clinic in psychiatry or neurology. And eventually it'll be part of a comprehensive whole structure, but we can definitely do that now. We do a lot of that already.
Right. Another question from Marina, who asks, is a memory care program covered by all insurances?
So it depends on the type of intervention we're talking about. So if a physician like I am, neurologist or psychiatrist, internist, see a person with dementia, they can bill Medicare or commercial insurance for the medical assessment. No problem. Standard of care. When Chris gets involved as a social worker, if Chris is doing psychotherapy services for a family member, that's covered. And if Chris is doing anything that looks like care management, helping people find resources in the community, Chris, I want you to answer this question better than me
Sure.
anyway. But tell me if I'm on target. If Chris is doing the non-medical stuff, care management types of things, or the activities in care ecosystem, there are two ways now to potentially bill for that, or two ways to recoup dollars for that. One is there's a code that Medicare put out about 4 or 5 years ago called the 99483 code. That code can be billed twice a year, and there are multiple components in the assessment that have to be documented. But that's one way to recoup some money for the delivery of the services like Chris can deliver. And then the guide model will have codes as well that you can use for some of these services that social workers and care navigators can provide. Finally, I think you can make a business case for this even for people in Medicare Advantage, because the way Medicare, again, this is managed Medicare. About half the country has managed Medicare. People in managed Medicare are not eligible for guide. They're eligible for everything else. But if you make the diagnosis of dementia, that adds to a bit of complexity to a person's needs. And Medicare Advantage will pay the clinicians providing the care more money based on the complexity of the person's needs. And if the health system is smart, they can use those added dollars to invest in people like Chris and dementia care navigators to support this type of model of care that we're doing at MGB and have been doing for a while. So it's a complicated answer. The reality is these dementia care models are not widespread yet, but with Guide, they're going to be all over the country. And the launching of the program and the first wave is going to be July 1st. Chris, do you want to answer that also? Because it's a great question. And
Yeah,
it's
so I think you touched on a lot of the salient points there. I will also say that in my line of work, because I'm working almost, I would say like 75 to 80% is with the family member, right? There are actually also specific codes that allow for billing of psychotherapy if I'm doing like a lot of counseling and I'm doing a lot of disease education and just overall care management with the family member in the interest of of caring for the patient. So there is still that focus that can be done that is covered by Medicare. We I The reason I know this is because we've been billing over the past couple of months, and that's basically the long and short of how we, pay for ourselves and charge for our services and make sure that we get reimbursed. So I would say the system is slowly coming around to and there's a shift in perspective in terms of how we're helping to care for patients with dementia. And I think that there is now a shift in focus to making sure that the family system, the caregiver system, is fully supported and that services designed to uphold and uplift those systems are being taken care of. So I think we're starting to see that now.
hmm, great answer, Chris. There are a whole bunch of questions now. I'll leave it to you to ask them.
Okay. All right. So moving right along here, um, Paula asks, is there a difference between Alzheimer's disease and frontal temporal dementia?
So as I mentioned before, there are many causes of dementia. The Alzheimer's type is characterized by these beta amyloid plaques and neurofibrillary tau tangles. The onset is gradual and slow. It involves the hippocampus of the brain first, and accounts for about two-thirds of all dementias. Very, very, very different illness than frontotemporal dementia. Frontotemporal dementia involves tau proteins built up in the frontal lobes, often earlier age of onset. Often the first signs are not memory loss. They're problems with executive functioning, like decision-making, planning, organization. And there may be personality or behavioral changes early on as well. As the disease progresses, it may look more and more like Alzheimer's disease with memory loss, but at the beginning, they look different. And because there's such a difference in the age of onset and the progression and the course of illness, Medicare actually decided a number of years ago, I think almost a decade ago now, to pay for these metabolic PET scans if the doctor is trying to decide between the two types of dementias. So if the doctors say, huh, is this Alzheimer's type or frontotemporal type? They can get a metabolic PET scan, Medicare will pay for it, and the pattern of metabolism changes are very different between those two conditions. I won't get into treatment, but let's just suffice to say the treatments I mentioned that are on the market for Alzheimer's, cholinesterase inhibitors, memantine, and even now the new anti-amyloid drugs, they will not work in frontotemporal dementia. So there's a huge need, and again, Dr. Dickerson's team and others, MGH and elsewhere, are doing a lot of work on novel and therapeutics for frontotemporal dementia.
Absolutely. All right. So the next question comes from Ahmad, who asks, how should one proceed if positive for genetic testing? And families at high risk for dementia, should they try the nicotinamide on their own? And if so, what dosage? That's very specific.
So the first question I would ask Ahmad and others who have this question is, why would you want genetic testing? How's that going to help change your understanding of your future risk or your potential benefit from treatment now? So let's say you're in your 50s, like I am, and you've got a family member like my mom in her mid 80s who probably has some cognitive problem, although not officially diagnosed. And there's no other family history of dementia. And if I did the ApoE4 test, the ApoE allele, and I found out I had one or more copies, would I do anything differently today? Not today, no, because I have no symptoms. Now, in 5 years, I might do something different because in 5 years, if we show that by treating people with plaque and tangle pathology in their brain before they have symptoms prevents them from getting dementia, then, oh, yeah, I'd want to know. But it's not the genetic testing that I would need to know that. It's really soon it'll be a blood test. Right now, it's an amyloid PET scan or a lumbar puncture. So or maybe you've got a family member who got dementia in their 40s and you're thinking about having kids and you want to make sure that they don't have an autosomal dominant gene or you don't have one that you might pass along to your kids. So there are rare cases in which there might be a clinical reason for genetic testing. And in every one of those cases, I would make sure that there's a genetic counselor involved to really describe the risks and benefits of this. Now, a lot of people go out and buy commercially available genetic tests like 23andMe and get a genotype the information on the genotype you'll get is the ApoE4 gene. But I would always ask the question, what do I want to do with this information? Because we all should be living the healthy brain aging lifestyle I described. That should be for everybody, regardless of risk. Whether you have high risk or not, it really doesn't matter. So if you are positive for testing, I don't know if I would change much, really. Again, the only reason I would get an ApoE4 allele test today for clinical reasons is if you're a candidate for lecanemab and you want to know your risk for side effects from lecanemab. Okay, so I can't answer that question any differently. The other part of it is nicotinamide riboside may or may not help cognitive and functional symptoms. We're doing the study now, and it's a pilot trial. So you could take it. It's harmless, usually, in terms of side effects. But in terms of benefit, I can't really tell you whether it'll help.
Okay. I would also just say that genetic testing, I think, comes into play if we're talking about advanced care planning. So if a person knows that there might be at higher risk given the result of the genetic testing, it might inform in terms of making certain decisions. Like the one that immediately comes to mind is something like long-term care insurance, which if you're purchasing something like the long-term care insurance policy at a certain age, it's almost impossible to get after a certain age versus if you're getting it a lot sooner in life. And long-term care insurance, at least in the world of social work when I'm working with families trying to figure out how to pay for care can be an immensely valuable tool, but it does not come cheap. And it's something that
No,
you would have to weigh in terms of decision making earlier on in life, as opposed to when you know you need it, but it's too late because you've already been given a diagnosis.
very
So
good
that,
point.
mhm. So there was another submitted question by a participant. How do you best approach a situation in which a spouse and or other family members are in denial? And I'm assuming denial in the context of a diagnosis for their loved one. Um, I'm curious to know your thoughts, Brent, but I also have some thoughts on this as well because this is like four
This is
fifths
your
of what
bread
I
and
do.
butter,
Yeah.
Chris. Yeah. I mean, we address this in the book. I mean, I would say that a lot of this is around education, and sometimes the denial and the minimization is really based in fear and worry um, about what the truth is. And remember, I talked about grief and mourning and all of that. I think a lot of those complicated emotions may be why the person's manifesting with denial. Like, I don't want to know. I don't want to know, so I don't see it. Um, it's a defense mechanism, denial, right? It protects us. It protects us from these feelings that are difficult. And so I think clinicians can kind of clinician like the two of us who kind of work with families a lot can kind of help in conversation understand what the denial is about and try to educate about what's going on. I find that sometimes objective evidence of the problem can be helpful in breaking through some of the denial. The performance on a simple cognitive test, for example, might open someone's eyes to a loved one who otherwise seems fine because they're speaking beautifully and they've got a high baseline educational attainment, and they may be functioning relatively well, but there are certain deficits that come out in testing. Or sometimes a picture is worth 1,000 words, and you have an MRI that shows brain atrophy compared to a normal brain. That's pretty dramatic, or even a change in metabolism in the brain with a PET scan. So sometimes you can show them objective evidence, but I think at the end of the day, it's really around understanding what the denial is about and having a conversation. But Chris, I'm curious what you think.
Yeah, so there are so many avenues to this. I think that in my day-to-day, what I tend to see is that number one, there's really something to be said for the importance of the interfamily relationship, interpersonal relationships between, the person diagnosed with dementia and those around them, and also the caregiver of the person with dementia and those around them. When we're talking about denial, and if we're talking about like extended family or, the larger family system, what I tend to see is exactly what you said, Brent, is that, a lot of it comes down to education, but it also comes down to where people are receiving the information in the first place. Families are complex. And if I've learned anything, it's that a message from a family member in terms of what's happening with a loved one hits very differently than a message about what a loved one is going through coming from an objective third party medical professional. Then the amount of times where I'm meeting with a caregiver or family member for the first time and they're expressing this very problem that, I'm trying to get my brother or sisters to the table, they just don't want to listen, they don't want to hear it. And I'm like, well, what if we have a family meeting and I can help sort of facilitate this conversation? We can go over and, we can kind of review the evidence that we have, and so that it's not just you saying what's happening. There is now this third party, myself, or whoever happens to be on the team that's part of this meeting, that is giving this objective view. Is like, hey, this is what's happening. This is not this is not just in the person's head. This is real, right? That to me is, I think, a lot of times, it's not perfect. People have their own views, and as you said, Brent, fear plays a big role. And if the relationships weren't really positive or supported to begin with, it's hard to bring people back to the table. But if, we're able to have that sit down, able to have that discussion and really say, this is what's going on to the best of our knowledge, this is what we understand, and this was how we really prepare for the future. The amount of times that I've seen a shift in perspective from families is astronomical, and I think it really underlines the importance of communication and being, having these integrated systems that are able to have the bandwidth to, push for those meetings, because it's really so important, especially, after an initial diagnosis. So
Thank you, Chris. We have a couple minutes. Maybe we can get through a few more. There's some great questions in here.
Yeah, so and I apologize to everyone if we're not able to get to your question tonight. We'll do our best. So, da, da, da. Okay, so I'm good. I think there's one more that I think we can, one or two more we can get to. Uh, I'm curious about whether there are significant numbers of advanced Alzheimer's cases where patients are not difficult, where there are no behavioral concerns. Do patients' personalities change dramatically all the time, some of the time, or how often?
There is no one rule here. Everyone is different, and it's really based on their pre-existing history of any kind of psychiatric problems. It depends on where in the brain the damage is occurring from the loss of brain cells and neural connections, deposition of these abnormal proteins or strokes, as the case may be. So there are plenty of people. There are some people with dementia, maybe about 5 to 10%, who generally have either very, very mild or no substantial behavioral symptoms. But that's the minority, not the majority. And sometimes the symptoms, even in the people who have them, are mild. So it's not everybody that develops severe agitation or aggression or personality changes. But it really has to do with where in the brain the disease is having its biggest impact, and whether there's been pre-existing issues. I'll just say one other thing. And I didn't address it, but this happens a lot. You may have a loved one with dementia who is relatively stable for like months or years. They're functioning about the same and their memory's about the same. And then all of a sudden, in a very short period of time of days or a week, it seems like they've fallen off the cliff, like they've gotten really confused or their behavior's changed all of a sudden. And some people may say, oh my God, their dementia is getting worse all of a sudden. Oh, I'll just say that dementia never gets worse all of a sudden. It's never just a progression of that brain disease in a week or so. It's usually something else going on. And that something else is very likely another medical problem, an infection, a urine infection, a pulmonary infection, a abnormal blood sugar level because they have diabetes that's poorly controlled, or they went on a new medicine that has side effects, or they have sleep deprivation or something else. But it's incumbent upon the medical team to try to figure out the why there's all of a sudden a progression. And that we call this a delirium, an acute change in mental status with poor concentration that may wax and wane over a period of time, and it's usually due to an underlying medical problem. There's another one about behavioral symptoms here, Chris.
The one from Karen?
Yeah, from Karen.
Yeah. So I was just about to get to that. Thank you. So I think this might be the last one we have time for. So Karen, thank you for your question. She asked, my loved one has crying jags and aggressive behavior in certain routines at the skilled nursing facility he is in. How do I get a doctor that is an expert in dementia, assess his behaviors and review his medications that he's on, and maybe help do a medication adjustment, either reduce his medications to get him on the right medication?
So if your loved one, Karen, is in a nursing home, a skilled nursing facility, and you're looking for an assessment there, which is appropriate, they should be evaluated there. Almost all nursing homes in our state of Massachusetts are very proactive of bringing in mental health clinicians to do this type of evaluation. Now, they may be a combination of psychologists, social workers, nurse practitioners, supervising psychiatrists, but there should be a mental health team of some kind that's part of the medical care team in the nursing home. And the reason why they're so common in our state in particular is really around the country increasingly is because there's a lot of regulation by Medicare on the use of psychotropic medications in nursing homes. And it's one of those areas that is highly scrutinized by the federal government. And they've been pushing for years to reduce the inappropriate use of potentially toxic antipsychotic medications, without really focusing, unfortunately, on the appropriate use of certain psychiatric medications. But be that as it may, there should be some help within the nursing home. So ask the nurse director, the social worker, the medical director, who here can do this. If your loved one's at home or an assisted living memory care facility or some other non-home living facility, there are a number of clinics in the Boston area and around the state that provide geriatric mental health care to assess medications, to see what's necessary, what can be removed, what new ones may need to be added. Brigham, Mass General, McLean, all three have great geri psych clinics. We have one at Tufts. Those are the four sort of academically based geri psych outpatient clinics that exist in the city of Boston, which is unusually prevalent. We have an amazing abundance of resources here, even though there's a lot of demand. Once you get outside of Boston, it gets harder. There are some people who provide this type of service in community settings, but they're fewer and far between. But geriatricians are great at this as well, really great at this, and some behavioral neurologists can do it. So it's really one of those three disciplines that can probably assess the kind of problem that you're describing here. Chris, do you have other thoughts on this? Because you're referring people constantly.
Yeah, I would also say that in general, like if I'm talking with a family and they're frustrated with their providers, if and especially if this is like outside the system, um, I would say that talking with the primary care provider in terms of getting a referral for a specialist, like let's say that if you have a primary care that's in the MGB system, and to refer somewhere like the geriatric medicine clinic or the memory disorders unit here at Mass General, it's a good way to get connected. And primary care providers are usually like the locus when it comes to trying to coordinate and find specialty services like that. So if you haven't already, Karen, I would definitely recommend talking with his or her primary care, um, and seeing what they can do in terms of facilitating referral to a specialist.
Absolutely.
All right, so I believe that is all that we have time for. We're at 7 o'clock. So, Brent, I want to thank you so much for joining us today. This was a wonderful conversation and a wonderful presentation. I'm hoping that everybody here got as much out of it as I did. And I want to just let everybody know before we adjourn that the Dementia Care Collaborative will be having a health and resiliency seminar on July 9th. It will be our chair Zumba class with Ketty from 5:30 to 6:30 p.m. So if you're interested in that, please feel free to join us. You'll receive a flyer and a reminder via the DCC mailing list. So be on the lookout for an email from us for that class. So, but again, Dr. Forrester, thank you so much for joining us tonight. I want to wish everybody here a wonderful rest of your evening. Stay safe, stay cool. It's like 90 degrees out there. And I hope everyone has a great night.
Thanks, everybody. Appreciate it. Thank
Thank
you, Chris.
you.
Thank you, Kyle. Bye, everybody.